este ciclo de conferencias magistrales. Tenemos temas muy interesantes con expositores realmente de calidad mundial. Y la primera plática está a cargo del doctor Alfredo Jenko, que nos va a hablar de este nuevo producto que ha salido para el tratamiento del sobrepeso y la obesidad, que es el balón gástrico o balón. Nos va a presentar la experiencia italiana, que fue donde pues, se hicieron algunos de los primeros estudios de este ovalón. El doctor Alfredo Jenko, muchos ya lo conocen, pero lo presento. Él es profesor asociado de cirugía general del Departamento de Cirugía de la Facultad de Medicina y Farmacia de la Universidad de Sapienza en Roma, Italia. Pertenece al grupo italiano para el estudio del LATAM y del balón intragástrico, y me honra presentar al doctor Jenko para que inicie su plática.
Good morning, everybody. Let me thank for this kind invitation. I'm here to present you our small experience using the new device of balloon, intragastric balloon, that we started using more or less 2 years ago. And we are making a good experience with using this new device, because this device gives us the possibility to treat the patient that refuses an intragastric balloon up to now. You know that many concerns there are around the use of intragastric balloon for many reasons, for safety concerns, because very often the physicians find it very difficult the placement procedure or the removal procedure, and sometimes the effectiveness of this device is not so clear. The balloon we are using now is a balloon completely different than the balloon we have been using up to now for many reasons. First of all, this balloon requires, the ideal balloon is a retained gas, strong withstand chemical and mechanical processes in the stomach, thin in a capsule. This balloon is involved in a very small capsule that the patient can swallow. It's biocompatible, is smooth and resistant. Well, this product is all over the place on the market in European countries. Is available in your country. In Brazil is going, our colleagues are going to start this experience. In Saudi Arabia we started this experience since September 2013, and we have been placing 100 balloons up to now. In Kuwait we are going to start in next September, and the clinical study for FDA approval is going on in the United States. Okay, this balloon is very easy, fast, it's customizable, it's very well tolerated, as I showed in a few minutes, and this balloon is actually work for three days. It is a swallowable balloon. This means that the procedure is not endoscopic procedures, because the patient may do everything by herself or himself. Is very well tolerated because it uses less symptoms than other balloons filled with air or with liquid that we have been using up to now. And then it is really adjustable. Why is it adjustable? Because this balloon, even if its volume is only 250 milliliters, we can adjust the treatment placing one balloon, or if needed, placing the second balloon, and for C, placing 3 balloons if needed in 3 months. As you can see, it is a very small capsule. The balloon is inside this capsule. The balloon is 250 milliliters filled with gas, with nitrogen. Its weight is only 60 grams. Only 60 grams. And this is very important because this is one of the reasons why this device induces less symptoms. It has a valve. This is a radiopaque valve, giving us the possibility to follow it during the placement procedure. In fact, the placement of this balloon doesn't happen in endoscopic unit, but in X-ray unit. It has a valve, this valve giving us a possibility to follow it, and it is connected to this film catheter of 71 centimeters. And over this balloon there is a capsule with the gelatin hydrophilic core. Why? What about the mechanism of action? The first mechanism of action is due to occupying space occupied, because we can feel when placing the stomach 250 milliliters, or double the balloon placing 500 milliliters, or placing the third balloon placing the stomach 750 milliliters. And then we know this balloon with many balloons induce a pressure alteration or induce influence of the receptor pressure allocated in the gastric wall by means this receptor pressure using the brain duct axis and the hormone like cholecystokinin and creatine. This balloon influence the center of satiety and the hypothalamus. Here you can see the capsule, the balloon, and the filling cells. Here you can see the can containing the 250 milliliters of nitrogen that we place here in the filling dispenser. We connect the dispenser with the catheter connected with the balloon just swallowed by the patients, and we fill the balloon. Let's go. So we go in the X-ray unit. The patient swallow the balloon. The duration of the procedure is 1 minute no more. We fill the balloon. We place the second or that we needed after a few weeks. And then when we arrive at the third month, we remove endoscopically the balloon using the device that we have in our endoscopic unit. Here you can see what happened when the balloon arrived and touched liquid, saline solution or gastric juice. Immediately the capsule delivers the balloon and we fill the balloon with the nitrogen. Then placing the liquid inside the catheter. When the liquid arrives here, the catheter is released by the. This is an example of how it is easy the placement. If needed, we can use water with gas, or Coca-Cola or something with gas. And the balloon immediately arrives in the stomach. And when we check by X-ray the balloon arriving in the stomach, we start filling. This is the procedure for removal the catheter from the balloon. As you see, it's easy, fast, no pain, no sedation. And after the procedure, as you can see, the patient is very, very happy. Okay, let's go how we can remove this device. The removal procedure is an endoscopic removal procedure. It is mandatory to remove the balloon after the end of the the third month. Otherwise, this balloon can deflate spontaneously. The patients can lose the balloon with small bowel. We go there with we need a needle that we used for the treatment of varices. This means that we don't need the dedicated device to remove the balloon. This is a needle that we use for polypectomy, for example, or when we perform the sclerosis of esophageal varices. In order to remove one balloon, we need 3 minutes. This means that we need 6 minutes when we have 2 balloons, or 9 minutes when we have 3 balloons inside. Who of you have been using other balloons filled with liquid and know very, very well how difficult is the removal procedure of balloon filled with liquid. Some balloons filled with liquid need to perform the procedure in operating room, sometimes general anesthesia during intubation. Here we can remove the balloon with using only sedation, sometimes without sedation. And when we use sedation, we don't need comfort because it's a very fast procedure. But we perform this procedure 98% of our patients using just 2, 3, or 5 milliliters of midazolam, nothing more. So, I invite you to notice another very important thing is that when I went inside the stomach, I didn't find food. Generally, when we go inside the stomach for removal of balloon filled with liquid, very often we found so much food. And sometimes we have to renounce the procedure and postpone the procedure the day after 2 or 3 days. Okay. Now, what about the food? This balloon is made to be used mostly in patients with lower BMI, even patients with overweight. Even if we have a little experience, as later I'll show you, of using this device in patients with a higher BMI, because we were very curious to know what will happen using in patients with high BMI using a balloon like this. This balloon gives us the possibility to use patients with overweight, and this is the truth, because the use of more invasive balloons in overweight patients is not suitable because of the severe post-operative symptom and post-placement discomfort with nausea, vomiting, and epigastric pain. So we have a great experience, an old experience of balloon filled with liquid. But up to now, for us, it was almost impossible to treat the patient with, for example, patient with overweight, for example, 28 of BMI with diabetes, because this patient refused the treatment with the balloon filled with liquid due to symptoms. The contraindications are more or less the same contraindication that you know when you use other balloon. Here we have to take care of patients who under diving and patients scuba diving and patients with we go in the plane not pressure to fly. Well, about our experience, the first thing that we say that we like to underline the patients when coming with us is that these intragastric balloons, like all intragastric balloons, are not a miracle. This means that we don't ask the patient to do a diet, because it is not enough. We say the patient that the intragastric balloon can help them to respect the diet, and this is very important because they have to do diet, helped by the intragastric balloon, but they have to change their lifestyle, performing physical activity. This is very important. It is very important in order not to achieve good results in terms of short-term results, but this is very, very important if they want to achieve good results and maintain the weight reduction and changing their lifestyle. This is very important. We have always to underline this aspect of the treatment. We provide a psychological support when we treat patients that are pediatric patients or adolescent patients, because in this group of patients we think that a psychological support is mandatory. Well, about our experience on 162 patients that finished 108 patients with a mean BMI, mean age of 41, mean BMI 37. You can see that in order to place this balloon we needed 3 minutes because the patient, the physician didn't do nothing. The physician checked only the arrival of the balloon inside the stomach. When we compare the placement of this balloon with the balloon like AP, we need at least 13 minutes during the placement. And then we remove the balloon, we need only, as I told you, 3 minutes per balloon, but we need 15 at least minutes to remove and fill the balloon like the BAD. About post-placement therapy, here you can see that we use only proton pump inhibitor for 40 milligrams at least for the first month, and then, if it's possible, we reduce the 40 milligrams to 20 milligrams. And during the first day, we use just 1 or 2 pills of antispasmodic, nothing more, no antibiotic because the antibiotic is not needed. But I invite you to see that starting the first day, starting a few hours after overload placement, patients are able to do a significant diet. This means that these patients are not to stay with us at least one day in the hospital. Look at what happened when we place a balloon like a PIV. We need the patient the first day doesn't drink and doesn't eat. We perform an intravenous infusion of 2,000 or 2,000 milliliters of liquid, intravenous proton pump inhibitor, and antispasmodic. Patients with an intragastric balloon like a PIP need to do a diet, semi-liquid diet for the first week at least, sometimes for 10 days. Starting the second day, patients with the balloon are able to start a solid diet made by our nutritionist. What about post-placement diet? No food with the PIP or balloon semi-liquid, the first 24 hours. And the second day, semi-liquid, PIP, semi-liquid, also the food with the balloon. And during the first week, semi-liquid with PIP and balloon solid diet since a few days. Here you can see one balloon. Look at this X-ray contrast medium of balloon, 2 of balloons. I invite you to see that due to nitrogen inside this device, this balloon doesn't go down, doesn't arrive at the antrum, must stay up in the fundus, where it induces stimulus for ghrelin secretion. And this is important that the balloon stay here. Now we see why. Other example of 2 balloons with the contrast medium. These are 3 balloons that stay always up. The balloons. This is an image of a balloon just filled. Well, if you want to evaluate the symptoms, evaluate the BAS score, you can see what happens when we place a balloon filled with liquid, nausea, epigastric pain, regurgitation, and the transitory vomit. Look at the difference between this balloon filled with liquid with the balloon, nausea, epigastric pain, regurgitation, and zero transitory vomit. It is a very important difference using this device. And what is very important is to evaluate this lines. We can achieve using 2 intragastric of balloon. More or less the same satiety we achieve with balloon filled with the liquid. And what we can achieve is the same satiety with very important differences in terms of symptoms. This is the first important reason why this balloon is completely different from the balloon we have been using up to now. Look what happened when we perform an ultrasound study of gastric emptying using a balloon like a balloon. When we use an ultrasound in order to see the food arrived here in the antrum, we need 10 minutes. When we place a balloon like a PAP, we need 300 minutes. When we use a balloon, we need 30 minutes. This means that this balloon doesn't affect the gastric emptying. And this is very important. Here you can see what happens when we go to remove an balloon, not put inside. And what happens very often, not always, but very often, when we go to inside the stomach for removal procedure of PRP. What happened? Here you can see the satiety curve, the pain and nausea, the symptoms. When the satiety, when the patient tend to lose the satiety, we are able to say it's a time to place a second balloon, and the same we can do a few weeks later. We place a third balloon. Placing the second balloon, the third balloon, we can adjust. This is very important. Another difference with the balloon used up to now, and that we can adjust the treatment in respect to the satiety of the patients. About the follow-up, the key for success of this balloon and for all balloons is the follow-up. Above all, using this balloon, the key for success is a very close follow-up. In our experience, we place the balloon, the patient is going away 1 hour, 2 hours later, after receiving all the information needed. And these are daily calls. The patient knows they have to call us every day to give us information about his clinical situation. If the patient doesn't call us, one of my team, physician of my team calls the patient in order to achieve the same information. And then after the first week, we meet the patient. Even the patient doesn't complain. We meet the patient. And then we meet the patient every 2 weeks until the end of the procedure. This is important. Why is it important? Because in order to know, in order to understand when is the right time to adjust the treatment, placing the second balloon or the third balloon, we have to perform a very, very close follow-up because we have to know the clinical situation of the patient, we have to know if the patient is losing satiety, we have to do the curve of weight reduction because when the curve is arrived to the plateau, is the time to place a second balloon or the third balloon. In our experience, and all experience, we place in the most patients the 80 balloons. This means that in 74% of the patients we place 2 balloons. Only in the 15% of the patients we place just 1 balloon. And in the 11% of the patients we place 3 balloons. This is very important because we perform this procedure, as I told you, according to the clinical evaluation of the patient, according to satiety and according to the weight reduction. This is important. This is a slide that where you can see an old balloon. And this is a Gary needle balloon used. A Gary needle balloon used in the 80s. It is a balloon with 250 milliliters of air filled. And this is a balloon that was a disaster in terms of effectiveness. This means that when we use one balloon that have the same milliliters of gas inside, we have to remember that this has to be the starting point of the overall treatment. This is very important. What about the overall patient's weight reduction? Here you can see that these patients no more able to lose just 1 kilo with the diet alone, now are able to lose weight point of 1 of BMI reduction, with about 10% of weight, of excess weight loss. If we go to see the patient with the lower BMI, we can achieve 4 points of BMI, and in the patient with the higher BMI, we can achieve 4.7 points of BMI reduction. These are very, very important in patients no more able to be treated to lose weight with the diet alone. What about the complication? In our experience, we had a patient with the gastric ulcers. Here you can see other complications we had using a PAP. We had one gastric perforation in the ulcers. Here, this is the patient. You can see the ulcer of these patients that have been using for a long time anti-inflammatory drugs, and it was not so very well covered using proton pump inhibitors. And this is another complication that, as you have seen, I didn't put it in the overall complication. Why? Because this is a patient that received a balloon, stayed in Italy to receive the second balloon, and then went to UK, and stayed in the UK for 5 months. This means that the patient returned to me 5 months. 2 months later, the timing for removal procedures, and when she came to me, arrived with abdominal pain and symptoms of vomiting and reflux. So I bring her X-ray unit, and what I found is what you can see here. Here is one of 2 balloons very well filled in the stomach, and this is a deflated balloon in the small bowel. This is another example of deflated balloon, the balloon in the stomach. In this patient, I didn't do nothing. I kept the patient 2 days with me in the hospital, intravenous infusion, very good proton pump, very good control of gastric and the volume of acid secretion using 80 milligrams per day of the proton pump inhibitor.